Welcome to Trinity Health IHA Medical Group Wednesday Wellness. Thank you so much for joining us this evening. Tonight's presentation is titled Managing Back Pain, and this will be a collaborative presentation with several teams coming together from the Trinity Health Spine Program, Trinity Health IHA Medical Group Neurosurgery, Probility Physical Therapy, and Associates in Physical Medicine and Rehabilitation. Our first speaker is the Trinity Health Spine Program Nurse Navigator, Michelle Davenport. Welcome, Michelle.
Hi, everybody. All right, so let's get this presentation going. Hello and welcome to our Wellness Wednesday. Our topic this evening is managing your back pain. My name is Michelle Davenport and I am a registered nurse with more than 9 years of experience and serve as the Spine Nurse Navigator for Trinity Health Ann Arbor. I will be sharing more about our spine program and how this free service is helping patients navigate through their back care. Did you know that more than 8 in 10 people suffer back pain at some point in their lives, and 3 in 10 have neck pain each year? To help this large population of patients, Trinity Health launched a spine program over 2 years ago. More than 1,400 patients have been assisted. One of the goals of the spine program is to help patients find the right care with the right provider at the right time. Patients come to the through the spine program through a referral from their physician, by calling the Spine 833 number, or through the emergency department, or by filling out an online form through a social media link. Back pain typically falls into 3 categories: acute, subacute, or chronic. Acute is back pain that happens suddenly and may last a few days to a few weeks. Subacute is back pain that can come on suddenly or over time and last 4 to 12 weeks. Chronic back pain may come on quickly or slowly and last longer than 12 weeks. This is important to know because it will help us determine how to best manage your back pain. As the nurse navigator, together we will fully discuss the type of back issues you are having. I will gather some additional health history information. We'll discuss any imaging you have had in the past or recently, such as X-rays, MRI, or CT scan. It will be important to know if this is a new problem or long-standing problem, and if you have completed any physical therapy or have had pain injections. Once this is completed, we will determine where to navigate you to so that you get the appropriate help you need with your back. In partnership with your primary care physician, the spine program will navigate to one of our 4 subspecialties: APM&R, Probility Physical Therapy, IHA Medical Group Neurosurgery, or Anesthesia Associates for pain injection. Your back history will help guide next steps. For example, if it's new back pain, you may first be referred to APM&R or Probility Physical Therapy. However, if you have been battling back pain for some time, you may be directed to IHA Medical Group Neurosurgery. Often, in order to see a neurosurgeon, recent imaging would need to be completed before seeing the surgeon. Seeing a neurosurgeon may also mean that conservative treatments have failed, such as physical therapy or even pain injections. Speaking of pain injections, many insurances now require completion of physical therapy. Let's learn more about how our subspecialties can assist you with your back. We have Dr. Young with us from APM&R.
Hello, let me get my video started. Sorry, can you help me with the video? It's not.
It actually looks like it's on. Do you maybe have something covering your camera?
No, I have nothing covering my camera. Oh, there it is. Can you see me now?
Yes, absolutely.
Okay. Hi, I'm Dr. Mala Young. I'm a physical medicine rehabilitation physician. I work at Associates in Physical Medicine and Rehab at St. Joe's for the last 8 years. Can we go to the next slide? So steps that we would take to manage your back pain. First, we'd have you make an appointment in one of our 4 clinics. We have a clinic at the main hospital in Ypsilanti, an office in Canton, Livonia, and Brighton. Kind of like what Michelle said, we're going to take a history to understand your pain. How long have you had it? What things trigger your pain? What helps? What treatment have you had done so far? Have you tried physical therapy? Have you tried injections? Then I'll do a detailed physical examination, looking at your strength, your reflexes, your range of motion, and then assessing focal areas of pain. Where are you tender? Is it over the spine, over the muscles? And then we'll review previous imaging and testing to see how that correlates with what's going on. I'm going to take all that information to figure out how that relates to your pain. So that's when we're putting the pieces of the puzzle together And then from there, we can establish a plan together on how we're going to modify your pain. So I always tell patients that I have 5 treatment options and there's no magic there. The first one is physical therapy, exercises, activity modifications. Maybe it's a yoga class or acupuncture, things that we can do physically to change our pain. 2 is medications. A lot of people are on anti-inflammatory medications or gabapentin for nerve pain. There's a variety of medications we can talk about. 3 is injections. So a lot of people know about epidural steroid injections into the spine, but there's also trigger point injections into the muscles. There's PRP therapy, which is platelet-rich plasma injections, prolotherapy, maybe some terms you've heard of. So there's different types of injections as well that can be done. And then the last 2 options are usually the less desirable ones, which is surgery or live with it. We always have an option to live with our pain, although that doesn't seem like the best option for most people. So we really have to look at what our treatment options are between those 5 categories to determine kind of what to do for you. So how do we determine what treatment of the 5 options we give? Well, the 5 options come in a manner of most conservative to least conservative. So we often start with therapy, but what are we sending you to therapy for? Well, it depends on what the cause of your low back pain is. Let's say you have low back pain because you have very tight hip muscles and you can't bend at your hips. So every time you bend, you're using your back. Well, the treatment would be physical therapy to work on your range of motion of your hips. Similarly, if you have a knee problem and you're limping because of your knee, your back is compensating, now you develop back problems. There's lots of various issues that can cause back pain that is not truly coming from your back. And that's really our job in PM&R, is coming up with the root cause of why you're having your pain. And only by determining the root cause can we determine what your treatment options are and really narrow it down for you in terms of what to do. So you might have done physical therapy before for the same thing and you say, hey, I don't want to do therapy again. Well, what did they do in therapy? Were they treating the actual causes of your back pain, or are they doing a generic back pain therapy? So it's important that we have a proper assessment so we can have proper treatment options. Other things that you'll see on this list, so leg length discrepancies, that offsets your pelvis. Even neck issues and mid-back issues can cause low back pain. Other things like constipation, abdominal issues can cause low back pain, and as well as pelvic floor disorder. So women after having children or later in life have issues with stress incontinence where maybe you cough and urinate a little bit. All those problems can be addressed through a pelvic floor physical therapist. So getting really to the root cause. And then obviously the last one is true spine issues. So is there bad arthritis in their spine? Do you have a disc rupture? Do you have enlarged joints that are causing pain? So we really have to ascertain again what the cause of your pain is to determine what your treatment options are. Next slide. Okay. So again, we have to, because we know that back pain comes from many different things, we have to treat all the different aspects of your pain. It can't simply be just do physical therapy. Maybe it's physical therapy and we need to treat the nerve pain with a medication like gabapentin, right? We have to treat all of the issues. And a lot of patients come, they say, well, I think I just need surgery. My back is terrible. Just send me to the surgeon. And I'm happy to send you to the surgeon, but we have to realize what part of your problem can actually be solved by surgery and what parts of your problem can surgery not fix. Sure, surgery can fix a bulging disc and it can fix a pinched nerve, but what about your hip tightness or your deconditioning of your body, osteoarthritis of your hip joints? Those things can't be fixed by surgery, and therefore you have to look at what all the problems are to treat. So that's where surgery might fix part of it, but then we still have to address the other issues with physical therapy, medications, maybe a referral to a subspecialist. So going back to the treatment options, it all depends on what the cause of your pain is. But I'm always going to start usually with good physical therapy, which is a great segue for our next presenter. Physical therapy is probably the most important thing in treating back pain and being physically active and taking care of yourself. The other things kind of fall into line as we need them. Thank you.
Thank you, Dr. Young, for your great presentation. Later in the presentation, there will be an opportunity for questions, so be sure to jot those down as we move along. As mentioned, physical therapy may be the first step to treating your back pain. Let's hear from Carl Boucher from Probility Physical Therapy on this topic.
Thank you, and thank you, Dr. Young, for that great segue. So my name is Carl Bush, and then here's my alphabet soup that's after my name. You can go to the next slide. So this is what everything after my name means. I have a doctorate in physical therapy. I'm certified in manual therapy. I'm certified in integrative dry needling, which dry needling is similar to acupuncture. It's more of a Western style. And I'm a therapeutic pain specialist. I did a 6-month course into treating complex chronic pain conditions such as fibromyalgia, complex regional pain syndrome, chronic fatigue syndrome, things like that, but definitely chronic low back pain is a big part of that. And I'm also a board certified orthopedic clinical specialist. I'm our director out in our Pinckney clinic. And on the side, I'll teach classes in pain neuroscience and neurodynamics. You can go to the next slide. And here's just a picture of my family. I just love, this is my wife, Catherine, and our puppy, Olive, and we're expecting twins in July. So lots of excitement to come. All right, next. So what I notice a lot when patients come to see me for low back pain is there's frustration around not knowing why you're having pain. And it goes along with exactly what Dr. Young said. We need to figure out what the source of the problem is. And I like to use this metaphor to help explain it to patients. And I want everybody picture an empty cup, and anything that could possibly be contributing to your back pain problem is like adding water to the cup. And that could be a joint problem, could be muscle issues, it could be fascia, it could be compensations. There's a lot of things that add water to the cup. But as long as the water stays contained, then you're not going to have a problem. You're not going to have pain. As soon as that water overflows, that's when your problem started. It's always easy to think, well, I lifted a heavy box, I twisted, I tried to put it on the counter, and I felt my back give out. That's it's much easier to understand why you hurt. But when you have pain start and you're not really sure why it started, there's no injury. I have patients tell me my back pain started, I woke up, I was stiff, it got worse throughout the day. And that was 2 years ago, and I still hurt. Why do I hurt? And even if you have tried physical therapy in the past, like Dr. Young said, it matters what things that they tried to treat. So we're going to do a comprehensive evaluation to figure out what the problem is. And those things in the cup, yes, it could be physical dysfunctions like our joint muscle, fascia, compensation, but it also could be what's going on in your life, sleep issues, nutrition. It could also be inflammation, tissue damage, any type of spinal degeneration. There's so many things that add water to your cup. As long as we can try to take out anything from the cup that we can control in physical therapy, that's really what our goal is going to be. And so a lot of times we take the water out of the cup and you feel better and we're good to go. Sometimes we control everything that we can treat and you still hurt. That's when we need to involve our other colleagues. And one thing I'm going to talk a lot about here is nerve sensitivity. So you can go to the next slide. So this is a picture. I like to show this to patients to explain what nerve sensitivity is, because a lot of times patients will come to me saying, I don't understand why I used to walk 3 miles. Now I can barely walk to the mailbox and back. What's wrong? So I like to show them this picture. On the left side is a normal response for your nervous system. On the right side is the sensitive response. So normally, all of our nerves have this low resting rate, meaning that there's always some electrical activity going through the nerve at all times. As you stimulate that nerve, it's going to increase its voltage, and that could be stimulated by pressure, stretch, temperature, blood flow changes, immune function, many different things stimulate the nerve. Eventually, it's going to hit this firing threshold. That's that red line. When it hits the red line, it sends a signal up to the rest of your nervous system saying, hey, there's something going on here. You might want to check it out. And that could be, you know what, it's actually pretty cold outside. You should put a jacket on. Or it could be, I don't really trust how our back is moving. You should probably look into this. And that's actually what leads to the pain response. So normally, we have a lot of room before we hit that firing threshold. But on the sensitive side, and nothing flares up the nerve like inflammation. when there's inflammation involved, or if there's some type of movement dysfunction, that low resting rate can get pulled up a lot higher. So now it takes much less stimulation to cause that same pain response. So you can see on the right side, that little bit of increase that can cause a pain response. Normally you wouldn't feel anything. Normally you'd be able to continue walking, continue bending, anything that any activities that you're doing. So what we want to do in physical therapy is find out what's causing that sensitivity response, try to lower it down so you have a lot more activity tolerance, and a lot of it's going to come down to exercise. We're nudging into some discomfort, but we're not trying to force through any pain is the idea. You can go to the next slide. And one of the things that we find is with the right exercise and the right treatment, we can get that sensitivity to come down and we can get your pain under control. But sometimes if we go through everything that we can control and it just doesn't change your pain, then we need to consult our other colleagues. But what we're going to do in physical therapy, I'm going to do an evaluation. I'm going to find out what things make your pain worse, what makes it better. Anything that does make it worse, I'm going to watch you do that motion and see if I can identify why it's causing your pain. We're going to optimize joint mobility. That could be mobilizations, muscle energy techniques, manipulations if it's appropriate. We'll do work with your myofascial system. So that's your muscles and your fascia together. And that could be myofascial release, trigger point release, stretching, any tools or modalities like we do some eye stim or any electrical stimulation. We could do traction. There's so many options that we have available. And I tell patients I'm going to keep searching until I can find something that changes your pain. And if we can just go a few weeks and we can't find anything that really changes it, I'm going to refer you back to the doctor, because there's something else that we can't change that needs to be addressed. And then also reducing, eliminating compensations. A lot of times that involves walking or squatting, any functional movements. The biggest thing we're going to teach you that's going to make an impact on your pain is the exercise. I tell patients that everything I do hands-on is going to be a short-term change. What makes it a long-term change is actually doing the exercises. So we're going to show you exercises that you'll do in the clinic, and you'll also be given a home exercise program that you'll be able to continue even after you're done with physical therapy. And like I said before, to reduce nerve sensitivity, we want to nudge into some discomfort, but we're not forcing through any pain. A lot of times patients come to physical therapy thinking it's going to hurt. It's not my goal to make it hurt. I actually want it to be as comfortable as possible. So we're nudging into some discomfort, but we're not forcing through pain. So I don't want people to be scared to go to physical therapy. And next. And here's some contact information. Something that we do is called the same-day injury assessment. If you ever have some pain that comes up and you're not really sure what's going on, and you try to make an appointment with your doctor, but it's a couple weeks out, you can always come in for an assessment. We can take a look, let you know what we think. We can even give you a couple exercises to get started with while you're waiting to see the doctor. But this is a phone number that you can call and set up an appointment. And if you do have any questions that come up for me, this is my email address. I'm happy to take any questions and I'll get back to you as soon as I can. All right, thank you.
Thank you, Carl, for that comprehensive understanding on how you would treat back pain. Our final group to hear from is IHA Medical Group Neurosurgery with Dr. Thawani.
Thanks so much. I'm having a video issue here, so I'm going to spare you, but this is kind of what I look like at this point. So I just want to thank you all very much for being here. I'm Dr. Thawani, a neurosurgeon at Trinity. I'm very fortunate to have all of the resources we have to take care of our patients, and the most important one being our team. You've heard from several of them. I work mostly at the Ypsilanti Ann Arbor campus, which is our most advanced hub with respect to neurosurgery. And all of our team members are board certified. Many are fellowship trained in spine. Next slide, please. So when you see a neurosurgeon or a member of our team, we take a focused medical history, we assess your symptoms, and perform a neurologic exam. And as part of our evaluation in the office, we'll sometimes order x-rays to better understand bony anatomy and sometimes spinal stability. MRIs, I think as Lori had mentioned, are usually important in the assessment. For some patients, we order MR imaging. And for most people, we're interpreting the images in the context of their condition. I often tell people in the office that we don't treat pictures, we treat patients. So just because there's a finding on a patient's MRI, it doesn't mean that it warrants surgery. It's very important for us to get to know you and your symptoms when you come in with back pain. Next slide, please. So the first job we have is to rule out atypical problems like tumors, infection affecting the spine, or blood vessel abnormalities. These things tend to be rare, but they're always important to look out for. As a neurosurgeon, I'm almost always trying to find conservative treatments to help with back pain before we explore surgical options. Spine surgery is all about careful patient selection. So in the appropriate group of patients who have not improved with conservative treatments, it might be appropriate to look into surgery. Those conservative treatments might include items that Dr. Bush and Dr. Young have already touched on: injections, medical treatments, various forms of PT might be used to help patients. Most people with back pain can be treated with conservative therapies. It's important to think about the anatomy of the spine and tailor our treatments to what we think the triggers of pain are. For some people, it's the disc. For others, it might be the joints in the back of the spine, for example. And some patients have multiple triggers. Next slide, please. So to figure these things out and maximize the effectiveness of our surgery, I like to meet patients in the office to get their history and go through their imaging. An important principle is then, how can we treat you in a less invasive way safely? And the key word is safely. Next slide, please. So I want to walk you through some of the commonly performed procedures that we do to help treat some patients with back pain. On the less invasive side of the spectrum, a microdiscectomy is a procedure whereby we remove disc fragments that are impinging or pushing on the nerves in the low back. This can be done through very small incisions, and typically we can send patients home on the same day. A deformity correction on the other end of the spectrum represents a procedure that we do. It involves more surgical time and resources. With a deformity correction, we're trying to reestablish more normal alignment in patients who typically have pain due to scoliosis or abnormal curves in the spine. Next slide, please. So as I mentioned, a microdiscectomy, it's an operation where a small incision is made and a retractor is placed. And using a microscope, we can carefully shave off a window into the spine and remove disc fragments that have herniated or moved away from the disc, pushing on the nerve. On the right, a laminectomy is shown, and that's a procedure where we shave off additional bone on the back part of the spine, creating a window that helps to free up compressed nerves in the spine. So although these procedures are done for reasons relating to leg symptoms, patients often have back pain as a significant component. Next slide, please. Fusion operations are done with the goals of decompressing the nerves and stabilizing the spine, which is sometimes required for patients. These are operations that are typically done with screws, rods, and many times inner body devices that go between the vertebral bones or bodies. All of these procedures I've mentioned can be done in a less invasive way. Using ports, we can perform these procedures through smaller incisions. We're also very fortunate to have a Globus spine robot, which has allowed us to perform complicated procedures like this in less invasive ways. So as such, many of our operations that would have taken place with people staying in the hospital for many days are now done outpatient or with very short hospital stays. Next slide, please. Deformity operations are a special type of case that we perform to realign the spine. So if you think about it, one major job of the spine is to keep the head situated above the pelvis. If there are alignment problems with the spine causing back pain, we'll need to use different tools to realign the spine. Oftentimes, we'll obtain x-rays in the office, perform measurements that help us to grade the severity. Next slide, please. Working in teams, we can perform these types of operations, which are some of the more advanced procedures in the spine. These pictures demonstrate some of the techniques we have to use, fortunately in smaller numbers of patients, to help restore balance. Next slide, please. So I want to take this opportunity to reiterate some of the goals that we had touched on. So first of all, our treatment goals should consider conservative, non-surgical treatments first. If someone needs surgery, however, how can we maximize the effectiveness and treat the problem safely? And finally, how can we minimize the invasiveness of surgery with some of the newer tools and advanced techniques? Next slide, please. I want to thank you for your interest and your time. It's a great pleasure of mine to be here with you or for your family members. I've listed my contact information here and be happy to help counsel you or your loved ones. Thanks.
Thank you, Dr. Thwani. With the information you provided, we have a better idea now of what occurs when seeing a neurosurgeon. We'll now take any questions that you may have from the presentation or just back pain questions in general. Please name the provider who you wish to hear from.
Yes, excellent. So there are already several questions. Again, if you would like to ask a question, please type it into the Q&A feature. It's going to be at the bottom of your Zoom screen. And do not type it in the chat if you see that option, because we may miss them in there. So it looks like there are a couple questions about some different conditions. So how about, I think this might be best for Dr. Thwani. What is a pinched nerve and how is it identified and treated?
Sure. So a pinched nerve is something that can occur due to several problems in the spine. And I would say the most common setting in which we see that is when someone has a herniated disc. People often liken a disc to a jelly donut, okay? And if the jelly component squirts out of the donut, it oftentimes will impinge upon one of the nerves as it's passing through the spine. And this can cause a sort of lack of blood flow or diminished blood flow through the nerve, which can cause dysfunction and result in pain. And that can occur due to a disc herniation, as I mentioned. It can also result from arthritis in the facet joints. So there are several conditions in the spine, mostly anatomic, that result in this. Another term for this is radiculopathy.
Okay, so for the physical therapist, they're asking, is there a daily stretching exercise that is most effective to help loosen up a back for the day?
It's a great question. And what I tell a lot of patients to do is right when you get up in the morning, before you get out of bed, just you're lying on your back with your knees bent and just let your knees sway back and forth. You're not pushing into anything that's painful. You're just trying to loosen up your back. And if all you can do is just a little bit of motion each way, that's where you start. Try to let it open up a little bit more as you go. Knee sways are one of the easiest things you can do to help loosen up in the morning. We also like to do some stretches for your hip flexors, because a lot of times, especially if you're a side sleeper and your knees are curled up and you're kind of in the fetal position, those hip flexor muscles can get pretty tight. So if you just look up hip flexor stretch on YouTube or in Google, you can find a lot of options for that. And the last one, if you can look up a QL stretch, quadratus lumborum, QL stretch, that's another one. A lot of times the QL, it attaches to your hip and your lumbar spine from the back. And if you can stretch out your QL, stretch out your psoas, and do these knee sways, a lot of times that takes care of a lot of stiffness that people get in the morning.
So Carl, there are a lot of questions around sciatica.
Yes.
Does that stretch where you're talking about being maybe a side sleeper or tucking your knees up, is that relevant for sciatica, or is there something else that people could do?
Yeah, sciatica is an interesting rabbit hole to go down, because yes, that could be helpful, but it might also not be the right thing for you. It depends what's causing the sciatic symptoms. Sciatica is a very general term that encompasses a lot of different nerve conditions. And depending on what's causing the nerve condition, those stretches could be helpful. It also could make it a little bit worse. So I would be careful to try it for just anything. If you have a stiffness in your spine, all those things I talked about are going to be great for it. If you have sciatic symptoms, meaning that you have either a numbness, tingling, a pain, a burning sensation, anything like that that goes down your leg, I really think that everybody should talk to their doctor about that first, and hopefully come to physical therapy and we can take care of it.
Okay, thank you. So we have some questions about bone spurs. Can anything be done for bone spurs on your spine? I'm not sure, maybe, I don't know if Dr. Young, Dr. Tawani, I'm not sure who wants to address that.
You know, a common effect from arthritis, which is inflammation of the joints, is the body tries to deposit bone in many instances to try and remodel and make sort of an effort to diminish inflammation. I think of those as bone spurs. Some of them are relevant and cause symptoms. Some of them are not. I think as a rule, we should not treat radiographic or imaging problems. So it really depends on whether those bone spurs are causing symptoms. And then number two, if conservative treatments can help, have not helped, then it might be reasonable to treat osteophytes or bone spurs. Yeah. I hope that answers that.
It did for me. I hope so. If you have more questions, just keep typing them in. We'll kind of keep scrolling here. And I did want to say, Carl, you mentioned a couple different stretches. Whatever documentation we have, or if we have any examples of those, we'll definitely share those with you, or links where you can find them. So if you weren't able to jot that down quickly enough, no worries. We will be able to supply you those resources. Okay. So this is a longer question. It's someone is asking a question for his wife. So she has degenerative disc disease, L1 through L4. She's been through physical therapy and been getting injections every 3 months to help manage the pain. Are there any other options for someone in her shoes?
I think degenerative disc disease is a very difficult condition. And I think the key is matching the patient's back pain with the degenerative condition. There may be other factors to consider in this patient's anatomy that might actually be contributing to back pain. It's difficult to know just based on the diagnosis of degenerative disc. It often goes with other problems.
Okay. Our attendees are often much smarter than I am. And so there are a lot of words here that I will probably trip over. So forgive me as I read this. Someone is curious if there are any non-surgical, non-exercise related treatments for like injection for spondylosis. Is that? Okay.
I can talk to that. So spondylosis is a very generic term for basically degenerative wear and tear changes that happen in the spine. So really over the age of 30, we all have spondylosis. That doesn't mean that it has to be treated. Other than exercises, it really depends on what your symptoms are from the spine. Not everyone has pain because they have some wear and tear in their spine. So it really depends on what the cause of your pain is. But physical therapy usually is the best answer. 10 minutes of exercise a day, 20 minutes, and keeping the spine happy.
Okay, excellent. Let's see. So there are a couple questions about different types of therapies. So massage and acupuncture, I think we touched on a little bit, but it looks like someone has some bulging discs and the massage and acupuncture are helping. Are there any other things that this person could try?
I can talk to that. Yeah, and like I said in the presentation, a lot of the things that we do hands-on, which could be acupuncture, could be massage, a lot of times they can be extremely helpful in the short term. And what we want to do to make it a long-term change is to combine it with exercise. The exercise is actually showing your body after, let's say we do some massage and we get things loosened up and things are feeling really good. Then we combine it with exercise to show your body, this is how you should stay. We're actually creating changes to your nervous system so that it stays more relaxed, and that will help to make a long-term change and keep the pain lower. So exercise is what I would say.
Okay. I haven't heard of this, a heated mattress pad. That sounds amazing. Are they good for to treat or to help with some of the symptoms of back pain?
I can talk to this. So heat can help for certain patients. There's no standard, heat or ice can be beneficial. You really have to test out what's good, what works for you. That being said, I would not recommend sleeping with a heating pad, especially if it's an electric heating pad, because you could cause serious burns to yourself. It's better to use it for a short period of time on and off than continuous like that.
Okay, makes sense. It looks like Michelle, maybe there's a question for you. So they're asking, what's the first step? So who do they call and how do they start their journey with the spine program?
So depending on if you're an IHA patient or not, a lot of doctors now are referring directly to the spine program. If you're not, you can simply just call our 833 number that's listed in the presentation. That'll connect you with me. I'm the only person that answers my phone, the only person that does my job. And then we'll kind of work together from that point. So there's a number of different ways. You can email me, call me. If you see one of my videos on Facebook or any of those platforms, you can click on that. It'll get you to me. But really just get in touch and then we'll kind of go from there.
Okay, perfect. And I think,
Allison, I actually have a question for Dr.
yeah,
Young.
go for it.
So this came in through email, but I know that the participant is in this presentation as well. So this person owns or works at an addiction practice in Monroe. A vast majority of the patients have ended up with spine and other orthopedic surgery starting at a very young age. That lead to pain, complications, and more pain and more surgeries to correct the new problems. Eventually, they get to the path of misuse, abuse, and addiction with medications. We hear lots of those surgeries may be avoidable or not necessary. What are your views on this, and how do we guide our providers so that their patients do not end up on this path?
Well, thank you for the great question. I think it stems down to, again, figuring out etiology of pain and going through the pathways of conservative treatment, starting with physical therapy, even if it's been done before. Oftentimes I see even from primary cares, the patient has back pain, they get an MRI. Shocking, the MRI has findings because the patient's over the age of 40 and there's going to be findings of arthritis, and then they get sent to a surgeon. Luckily, we work with great surgeons here at St. Joe's, and they're going to look at those other causes and they're going to say, hey, no, this is not someone we need to operate on. This is not their source of pain. So it's really selecting the right people for surgery, which Dr. Thawani can talk about more, but it's using the other treatment modalities available. I don't prescribe narcotics to my patients for back pain because that doesn't fix the problem. That's masking symptoms, and studies show that it doesn't help with chronic back pain. So it's really the right treatments to start with. And then if we deal with an addiction, is getting them to the right providers to help them with that addiction.
So I agree completely with Dr. Young. And I think that when I think about my practice, it's much harder to tell a patient that surgery may not be appropriate than it is to offer surgery to many patients. And I don't think it's right to offer surgery to younger patients in particular if there are other alternatives. So I think that with young people, we need to think a lot about the duration of their lives and how their spine will age over time. And impacting them with permanent solutions can really set them on an unfavorable trajectory. Opiates, narcotics, they're a big problem in our society. And I think that the way that we look at patients, the way that we treat them has changed significantly, even since I started training. And I think that we do a much better job of promoting other medications, weaning patients off of stronger opiate medications after surgery. And it's a team approach. So it's not just the surgeon, but it's the folks in our office, our nurses, who help to create weaning schedules for medications. And a lot of it's also expectations. I don't tell patients that they're going to be 100% pain-free after surgery, because I don't think that's true. So I think that their expectations need to be managed, and we need to tailor our treatments to those individuals.
Okay, it is so interesting how all of these symptoms, all of these different conditions really are so individual that everyone has a different cause, a different symptom maybe. So it is interesting to hear how you guys can work through that investigation together. There are several questions about scoliosis. So there are people wondering if there are things that can be done to treat it without surgery. I don't know if you want to address that first, and I will give you.
I
a
can
follow-up
answer some of
question.
that. I would say absolutely. And there are various types of scoliosis. One type affects adolescents. Typically, that's the type that is screened for in schools and similar settings. Those types of patients many times can be treated with just surveillance or even bracing. There's degenerative scoliosis, which is something that tends to affect people more with age. That's the type of scoliosis that I tend to see more of. So there are different considerations with, let's just say, those two groups. Adolescents, younger people tend to have very strong bone, and they have a lot more mobility in their spine, whereas patients with degenerative scoliosis tend to be a little bit older, and we have to consider their changing bone health with age. They have very, very different treatment paradigms with just those two groups. So scoliosis doesn't necessarily have to be a surgical condition. And a lot of times patients have minor scoliosis that doesn't require anything other than just observing it.
Okay.
From my standpoint for scoliosis, one of the most beneficial things I can do is give patients trigger point injections, which are injections into the painful muscle alongside of their spine. Because of the scoliosis, they're one way or the other, and that can be very painful. So along with, telling them to do daily stretching and exercises, foam roll, massage, and things that I'm sure Carl can talk more about, we can do these types of injections, which could be done every 3 months to help alleviate some muscle pain associated with scoliosis.
Yeah, and when they come to physical therapy, anyone in our clinics can treat scoliosis, but if it's a more severe case, or especially with adolescents, we like them to go to our specialists. So we have a couple people in the company, one's in Brighton, one's in Clark Road and Ypsilanti, that will treat youth with scoliosis and make sure that they get on the right path. A lot of it is there's going to be hands-on treatment they can do if it's below a certain degree curve, but also a lot of exercises that the patients can do. And sometimes it involves bracing. It just depends on how significant it is.
Okay. And how about compression fractures? There are several people who've asked questions. I'm trying to pull them all together here so we have like a common theme. But there are a lot of questions about compression fractures. It looks like someone fell off a roof at one point.
I can interject, Allison.
Yeah, please do.
So actually, I think it would be helpful for most of the people in the group to just understand how we treat compression fractures. A lot of patients will go in and they'll get the x-ray that they've had when they don't know, if it's an old compression or a new compression, but they think surgery is the only option. I don't know if Dr. Young or Dr. Thawani want to address that.
I'm sorry, you had asked about compression fractures and whether or not surgery.
Right. What would be the best way to treat them to start?
So there's a spectrum of compression fractures, and depending on the level that's affected and the patient's symptoms, they might require surgical treatment. Typically, we reserve treatment for compression fractures that cause debilitating pain or symptoms, or ones that progress, meaning that the abnormality that we see on imaging, if it gets worse over time, that might compel us to treat surgically. One surgical option is to inject the compressed body with a type of cement. the effectiveness of that procedure really depends on individual patient factors. So it really requires someone looking at you and evaluating you for that kyphoplasty procedure. Most patients, in our group's opinion, are not great candidates for kyphoplasty. And we tend to try medications, sometimes bracing, so braces that go around the patient's bodies. Those tend to be our most favorable practices for compression fractures. Now, we'll bring patients in to get x-rays periodically. Sometimes we'll see the patients during these visits. Sometimes our physician extenders will see the patients. And I think ultimately patients do tend to get better over time as long as there's not a big change.
Okay, perfect. And there are a lot of questions, I think, for you, Michelle, on how do we reach you and asking about self-pay and some of those types of things. So Michelle is the person you will talk to, as she said, which is, I think, a really unique part of this presentation, that you get to see the person that will be your first point of contact. And we will reshare the contact information for Michelle, absolutely. And any of the questions about insurance and things along those lines, is it best to call you and talk through that, or what's the best step for people who are wondering about that?
Yeah, definitely, because everybody's insurance is individual, and it's depending on who you are and what your situation, it varies. Like, there's many options. So let's talk it through. And even if it's something that I might not be able to help you with, I will find the right help that you need. So if you could just connect with me, like I said, through email or phone call through the next week or so, we'll touch base and figure it out.
Perfect. And actually, you will receive a survey following this presentation as soon as you log off, and it will give you the option of being contacted after. So if you would like to fill in your name, email, and phone number, I'd be happy to share that with Michelle, and she can reach out to you in the coming days or week. Okay, there's a question about whether or not some of these pains and spine issues can be hereditary.
Yeah, so it is interesting to see that a lot of times there is a hereditary component to this. Our spines, and especially the discs themselves, are designed to take a lot of force. And when there's a certain level of force, and it's hard to know, we can't really say what it is person to person. I do think there's good evidence to show that your genetics will determine how much force is considered too much for your body. And then there's different physiologic processes that happen within the disc that cause the degeneration response to that. So people who have issues in their family with spinal degeneration tend to have more spinal degeneration themselves, but it's also not guaranteed. It's one of those things that, depending on what you do in your life and how you take care of your back when you're younger, and if you do have some type of injury to your back, do you rehab it correctly? That actually tends to determine more whether or not you have degeneration with your spine later on. Dr. Young made the comment a couple times that it's normal after the age of about 30 to have something that you see on an MRI. There's some kind of degeneration component. We consider these to be just wrinkles on the inside. These are gray hairs. You can see them, but they're not necessarily causing the problem. And Dr. Thawani made the point that we're treating patients, we're not treating pictures. I love how you said that. That was so perfect. So when we see a patient coming in, we may be able to look at the MRI report, and there may be a lot of things listed there that have nothing to do with your pain. But sometimes we can look at it and say, yes, this might have a good impact on your pain. Let's see if we can do some kind of treatment for it. So there is a hereditary component, but it doesn't mean that you're going to have a problem.
Okay, so I think this person, it sounds like she had an aunt and a mother who experienced back pain in their 40s, and I think it's now creeping up on this person in their 40s. So it sounds like there may be a hereditary component there, but of course, the best first step is to call Michelle. Okay, can we touch on osteoporosis? There are several questions on that. Looking for different treatment options, what can be done to help maybe prevent some of the damage done there. Can you guys touch on that and how you help your patients that have that diagnosis?
For osteoporosis, I mean, first you'll need a bone scan to take a look and see what your bone density scan to see what your bone density is like. And there's supplements that your primary care can prescribe you. Weight bearing exercises are really good for bone strength and bone health. And really what is the root cause of your osteoporosis? Again, that's how you have to treat it. So there's supplements and then exercise.
Correct. I tend to advocate for the use of vitamin D3, getting at least 2,000 units per day, especially in patients that are shown to have osteopenia or osteoporosis. I don't hesitate to refer patients to endocrinologists if they require more advanced therapies. Typically, women at the age of 65 are recommended to have bone scan studies, to my knowledge. And then for men, it's usually 70. So if I see patients have not had these done, or if I see signs that they might have these problems, I'll usually get a bone scan study and then refer them appropriately.
And really, you can start taking those vitamin D3 in your 20s, 30s. I mean, you don't necessarily have to wait until you need a bone scan to start those vitamins, correct?
Correct. I agree with you. I think in Michigan, we suffer from a lack of sunlight, and
Yes.
I think many patients are deficient. We do actually check that lab level in patients undergoing corrective operations, and we see many patients are low.
Okay. And if it's something that you're maybe not experiencing back pain or other symptoms like that, but you could have that checked just with your primary care physician, maybe an annual exam.
Correct. Yeah.
Okay. All right. This person, I'm going to read their exact question. She says, I had a microdiscectomy in 2018, immediate relief. One issue I'm having now and for the last couple of years is getting some pain down the leg where the original pain was. It tends to bother me more if for some reason I'm driving more than a couple hours. Is that just an after effect?
That's a good question. It's very hard to answer just based on the history. I would definitely want to take a look at your imaging studies. And, one thing we have to assess for is not just a disc herniation or a recurrent disc herniation, which can happen usually 4% of cases, but also changes in the facet joints. So the nerve tunnel where it exits the lumbar spine, it's bordered by the disc and by the facet joint. Okay, if there are bony changes in the joint, or if there are osteophytes or bone spurs, that might be a cause of someone having recurrent nerve root irritation, sciatic symptoms. And I hope that makes sense. It all depends on the imaging studies. Regardless of what the imaging studies show, however, I would probably try conservative treatments. So an epidural steroid injection is an injection of steroid, the strongest anti-inflammatory drug we use, right around the space where the nerve is. And typically, it can help us in diagnosing where the problem is. So for example, if someone has multiple levels where there's arthritis and disc problems, and you have the patient injected at the same level where they had the discectomy, and if that patient improves, that tells us very likely it's that same nerve root that is inflamed. It can help diagnose in that way. And it can also help in treating inflammation because steroids tend to pervade very deeply into the nerve and cause an anti-inflammatory effect that tends to last for some time. So just because someone has symptoms again, doesn't necessarily mean they need to have surgery again. And I think we should always evaluate patients on a case-by-case basis and look at them in a non-surgical way.
Okay. Carl, there are several questions about red light therapy. Can you talk about what that is?
To a certain extent, I actually don't know that much about the research on red light therapy. I consider it to be another one of the modalities that we have available to us. But I also think that like all other modalities, it's a short-term effect. It's not something that I consider to be our main treatment that we're going to use for patients. I lean towards manual therapy, and I like to do dry needling as well. And I do a little bit with some modalities, but then the exercise is the main component that we're going to use. So I unfortunately can't speak about red light therapy too much. Maybe some of my colleagues can.
Okay.
I can't say anything about red light therapy particularly in specific, but there's always a new modality that's out that is the new craze, right? When cupping came out, everyone wanted to get cupped. Then it was dry needling came out, everyone got it dry needled. Now it's red light therapy. There's all sorts of different things that are going to come out, and everyone thinks it's going to be the new thing to save them. Well, it's another tool in your toolbox. That's really what we're doing with therapies, finding tools that help you. Maybe it helps you, maybe it doesn't, but it's not going to be a catch-all for everyone.
Okay. And some of the other different tools in their toolboxes that they're asking about are electrical nerve stimulation, and then also the tape that I think we often see like the football players wearing, or those types of things. Are those pieces or parts that you guys use to help treat patients?
Yes. So again, it's something that can be helpful in the short term, like a use of a TENS unit can be useful to stop somebody's pain right away. But as soon as you stop using it, it's gonna come back. It's not a long lasting effect that happens with it. So if we can use it appropriately to help try to manage some pain, we in the clinic here will use a TENS unit while somebody's doing exercise if they really need it. If their pain is too high, we can do things to be able to get their pain down and allow them to exercise more comfortably, because that's what's really going to make the change. And I forget the other one was taping. Yeah,
Yes.
just real quick about taping. It's really helpful in the short term. We find that for about 2 weeks or so, we can get some good changes with taping, but after that, it doesn't really seem to do that much.
I've got 2 questions. The first one is to address prolotherapy. It was just mentioned, not really explained what it is. There is a person in here who has a seriously arthritic ankle, and told surgery would be very complicated. So they were wondering if prolotherapy is something that they could consider for treatment.
Yeah, I can talk briefly about prolotherapy. So prolotherapy is the idea of causing small amounts of acute inflammation and damage in order to heal your body, to have your body heal itself. So essentially, sugar water is injected into the damaged tissue or ligament or tendon, and then that will trigger your body's own response system to send healing factors to that area to heal the tissue. So a chronic injury that could be micro re-injured can then heal. I would not know in the case of your ankle injury, you'd have to be assessed either by a PM&R physician or an ankle surgeon first to see kind of what's going on, if that would be something you'd be candidate for.
Another question might be better for Carl. A lot of people are asking, is it best to do chiropractor versus PT, and what's the biggest difference?
That's a great question. It's one I get all the time. And it's something where we can do all the same things, chiropractors and physical therapists. A lot of it comes down to our treatment, the theory behind what we're trying to do. In physical therapy, we tend to believe that the exercise is the thing that makes the long lasting change. And a lot of times with chiropractors, some of them do incorporate exercise, but a lot of them historically do not incorporate exercise. So that would be the biggest difference. We can do all the same manipulations that chiropractors can do. We tend to use them less. We tend to focus on more movement therapy in general. But both of us, I think, can do really good for people.
I'm just going to piggyback on Carl because I get this question from patients a lot. And it's the same thing. It's a chiropractor can fix the derangement in your spine and get things feeling better, but the problems that led your body to that issue in the first place are still there. So weak muscles, tight muscles, lack of flexibility, and that's what physical therapy is going to give you the complete picture, so that you don't have to come back every 2 days for the rest of your life like you do to the chiropractor, because they're going to help you fix yourself instead of just adjust you for a temporary time.
Okay, I'm gonna kind of scoot through and see if we missed any other major questions here. It looks like we do have a few people who are living in different parts of Michigan, maybe not super close to our southeast location. Are they able to be seen virtually for some appointments? I'm guessing not for physical therapy, but is there an option where some of the people from the Upper Peninsula, let's say, would be able to actually be treated, or could we maybe help them find someone in their area?
Yeah, we do virtual appointments for in physical medicine. The hard part is you can't do a physical exam, and so much of the information that we get in terms of etiology of the problem in order to treat it is putting our hands on patients. I can get a lot of information from a history. I can have you walk and do certain things. So if the option is no exam or a virtual exam, I would say virtual, but I would feel incomplete about that treatment plan. So I'd probably want to help you find someone locally.
Yeah, it sounds like it would have to be a hybrid option at best,
Right.
right? Yeah. Okay. There's a question here from someone who is being who has back pain throughout the night, and it wakes him up 4 to 5 times during the night. He gets out of bed, does a walk for about 10 minutes, and then gets temporary relief and is able to go back to sleep. Any recommendations for this person?
Send them to Carl.
Perfect answer. Yeah, that's hard to know exactly what to do until we do a physical exam. One of the issues, well, when you lay down at night and you're sleeping, your blood pressure drops. And a lot of times with a drop in blood pressure, things that may or may not be getting proper blood flow normally, that can get kind of irritated. Something like spinal stenosis that we already talked about can potentially reduce some blood flow to an area. So we want to figure out what's actually causing your problem. It could just be muscle tightness that's causing a reduction in blood flow during the night. Your body wakes you up because it doesn't like not getting blood flow to a certain area. You wake up, you stand up, move around. Moving actually gets blood going faster and it pumps it into that area and makes the nerve happy. That could be part of it. We just need to figure out what's actually going on.
Okay, and so somebody's asking if walking is good for lower back pain. Well, it sounds like it could be. It's okay, perfect.
Usually it is a very good thing. You would want to figure out if the walking is pushing you past a certain level of pain, then we would not want to do that. But for the most part, walking is going to make your back a lot happier.
Okay, and then there are a couple questions about mattress toppers, wondering if those are harmful or helpful. So it sounds like it really depends on the individual and why their back is hurting. Okay. Okay, and if you have a compressed fracture, is it okay to get some of those hands-on treatments, whether it be massage or an adjustment? Do you have to be careful?
Yes, I'm not going to adjust. So I would call it manipulation. I'm not going to do that on anybody with a fracture because that's very dangerous to do. Things like gentle massage, though, is not going to cause an issue. With depending on what the fracture condition is, kind of like Dr. Thawani talked about, it depends on what the compression fracture looks like. I think that getting imaging of it first would be the big thing, and if your doctor believes it's appropriate for physical therapy, then we'd love to see that person.
Okay. There are some people who say they're even sleeping in a recliner. I know that can be so miserable when you're being awoken by something like that. Okay. And then maybe just a couple more questions. I don't know, Michelle, if you have a couple or if you see a few you want to shout out or you think would be worth addressing. I know you talk to people with back pain very often, so you might see some common themes there.
A lot of the questions that patient or the persons attending are asking are very specific to them. And in those situations, I think it would be great to touch base with me in the following weeks. Like I said, through whatever contact works best for you. And then we can talk through all of the different options that are available to you. Let's see. A lot of people are asking about neuropathy and just nerve pain in general. If there's anything that they can do when they're waking up in the morning, is it best to do heat or ice? What treatments can they do as far as stretching goes to help with those types of pain?
So neuropathy is a complex issue. Neuropathy means damage to the nerves. Most commonly is diabetic neuropathy, when patients with uncontrolled diabetes get numbness and tingling at the tips of their toes, tips of their fingers, and then that neuropathy works up their leg. There's other neuropathy that people develop just because of age. There's other causes of neuropathy. It's really, again, treating what the cause of the neuropathy is. There are medications like gabapentin, Lyrica that can help with neuropathic pain. There are ointments that can be applied, and I'll let Carl discuss any other things that he thinks exercise-wise.
Yeah, I would say exercise-wise, what leads to neuropathy? There's a lot of things that Dr. Young just talked about, and a lot of those things are causing the tips of the nerve to degenerate. So what we can do, how do we make a nerve stop degenerating? A lot of times we can do that with fixing the original problem, which could be a sugar issue, it could be something else. But one of the main things that make nerves happy is movement. So we know that the transport system within the nerve that keeps the nerve healthy, it brings in new cell components and it takes out waste. What makes that system work faster is movement. So if you move the nerve, it actually speeds up the transport system that heals the nerve. And people with diabetes tend to have a thicker transport fluid within the nerves. So a thicker fluid is not going to flow as fast. So it's even more important for somebody with diabetes to be moving. And simple walking would be great. The problem is, well, it hurts when I walk, so I don't want to walk. That's when you need to come in and see what we can do to get your back feeling better or whatever's not feeling good when you walk. And then you can get more motion throughout the day. And there's specific things that we can show you. Even if you can't walk, we can show you how to do nerve glides to get the nerves moving. And that might be able to take down some of the pain as well. Not going to fix the problem. We need to figure out what's actually causing the neuropathy first, but we can do some things after that.
And does that include people who are maybe not having as much pain with neuropathy, but more balance issues?
Well, we definitely, if somebody is having trouble feeling the bottom of their feet, that's going to make their balance more challenging. So that would be something also that we would work on, would be balance with that patient. It's not going to fix the neuropathy problem, but it will prevent them from having a more serious problem from a fall, hopefully.
Yes, definitely. Okay, Michelle, if you want to scroll through, if you see any other questions you'd like to address before we close out our webinar, that would be great. And I will just repeat again, we will share contact information for all of our speakers as well as Michelle at the spine program at Trinity Health Ann Arbor. And you will receive an email in the next couple of days, if not tomorrow. And this will also include a recording of the presentation, so you can go back and listen to any pieces or parts that maybe you missed or would like to give another listen.
So one of the questions too that keeps coming up is acupuncture versus dry needling. What does it exactly do?
Great question. I can take this one. So the difference between the two, dry needling is more of the Western style. Acupuncture has been around for 6,000 years, and it's mostly to do with meridians. So trying to change energy flow, working with your chi. When I do dry needling, I'm not worried about doing that. What I'm trying to find is either a muscle that is really tight and I'm trying to get it to relax, or I'm trying to bring more blood flow to a certain area. Usually I'm trying to bring more blood flow to a peripheral nerve pathway. In the case of low back pain, if I determine that I think the cause of your low back pain is that some joints in your lumbar spine are not moving enough, or they're stuck in a little bit of a rotation because these muscles are really tight, I can put a needle right into that tight muscle and usually get the muscle to twitch. When it does that spinal reflex twitch, it relaxes after that. And then again, that's not the fix. The fix is when we combine that with exercise. But the dry needling can be really helpful because when I get the muscle to relax, not only is there an immediate effect, but there's a small wound that your body has to heal. And by healing that area, it actually makes it less sensitive. Immediately from any type of wound, even if you just get a little scrape, there's going to be an inflammatory response. And if it's a very small wound, that inflammatory response only occurs for less than 24 hours. It happens to be a really quick healing response from dry needling. And then the cool thing that happens is that there's a rush of anti-inflammatory chemicals that come in. It's your body's way of saying, stop, we've cleared out the damage, everything's good. Let's let this just be now, let it be. And those anti-inflammatory chemicals have an effect around the whole area of your low back. So there's some cool things that come from dry needling other than just getting a muscle to relax. But it's really the exercise that we combine with it that makes the long-term change.
Maybe another question for you, Carl. What are good exercises for persons that are now sitting in front of their computer all day, that are working from home, things that they weren't normally moving before?
Yes.
And along with that, is there any way to slow the progression of degenerative changes in the cervical spine?
And the biggest thing to stop degeneration is going to be our posture. And that those two questions definitely go hand in hand. So when you're in front of the computer, there's ergonomic changes that I would do to everybody's workstations. A lot of times when people shifted to working at home, their office setup was not the best. And either their computer monitors were too low, or maybe they're working on a laptop that's in their lap and not actually up on a desk. We want to have our monitors right in front of your face. You don't want to have to look down, look up. You want the monitor right in front of you. And the second thing is you don't want to have to reach for your mouse or your keyboard. So you want the mouse and the keyboard in a position where you could have 90-degree angle with your arm, with your elbow. So 90-degree angle with your elbow to be able to reach everything you need. That prevents you from having to reach out. That will bring your shoulders forward, bring your head forward, all those issues from having a poor ergonomic setup. Make sure that you have both feet flat on the floor. And if you don't have a chair, if you have a chair that, let's say it's a little bit too high and you have shorter legs, make sure you get a box to put under your feet. You don't want your legs dangling for too long. Exercises you can do once you get your ergonomic setup. I tell patients, if you're having an issue with neck pain or back pain from working on a computer, you want to do these exercises every hour. I would say 10 of these scap squeezes is what they're called. So a scap squeeze looks like this, where I'm just squeezing my shoulders back and just holding it. You're not going up, you're going back and down with your shoulder blades, like you're trying to put them in your back pockets. And if you can hold them back and down for 5 seconds, just hold for a count of 5 and then relax. Do 10 of those every single hour when you're working. That a lot of times that can help to reset your posture during the day. There's other things that we can do too, but I would like to just keep it basic and set up your desk space well. That's more important than anything. If you're going to be on a computer for a long period of time, make sure it's set up for you. And then the second one is 10 every hour, do these scap squeezes. And you can look up a scapular squeeze online as well if you need to see a picture, but we'll also put it in the notes afterwards.
Yes, definitely. We will share that. It sounds like a great thing to pop in a calendar or any kind of device you have to remind you. I know they remind us to stand, so remind us to squeeze our scaps. Something along those lines. Okay, and I saw Dr. Tawani was answering a couple of questions. Are there any others in here, Michelle, that you would like to address?
Well, actually, because I'm actually not sure myself. Is
Okay.
tissue regenerative therapy something that we perform within Trinity?
No.
And then let's see, what else do we have here? Some patients are asking about different medications as far as gabapentin or Suboxone go. Are those better questions addressed with their primary care providers?
I can talk to gabapentin. I mean, gabapentin's a medication for nerve pain that works fairly well. There are side effects that include drowsiness. Sometimes people feel off, a little bit dizzy. Side effects can be worse as patients are older. But it can be very useful for nerve pain. That your primary care can prescribe it, or a physical medicine doctor can prescribe it. It is a controlled substance, though.
Is that something that can be taken long-term? A gabapentin?
Yes.
Okay.
Gabapentin can be taken long-term. It can also be taken, while you're having nerve pain, if that's a few times, for a few months, or sometimes people just take it at night because they feel their nerve pain more at night when they're in bed. And it does have a side effect of making you sleepy, so that can be helpful.
Do we have any recommendations for patients who are in an acute exacerbation of pain? So they've been totally fine, have an acute pain flare-up, maybe seek some treatment at urgent care, PCP, the pain goes away. Should they be worried about it returning?
I think it depends on what the cause of the pain was. Oftentimes symptoms return. I would still recommend getting evaluated and likely going to physical therapy.
I think we've addressed most of the questions, Allison.
Yeah, I think you guys did a great job. Thank you so much for spending all this time answering questions. And I know there are some questions about, it looks like contact information for Carl and Dr. Young, and we will absolutely share that, as well as Dr. Tawani and Michelle, of course. So again, thank you all so much. It was so wonderful to have the whole team of people who you have at your disposal here right in front of you to be able to answer all kinds of questions from every aspect. So we appreciate all of your time, Dr. Young, Dr. Tawani, Carl, Michelle. We appreciate you guys for being here and for taking the time to present. Again, a survey will pop up at the conclusion of our webinar, and you are able to fill in whether or not you would like to be contacted by Michelle. And if you would do that, please include a phone number where you can be reached, as well as your email if that's a better way to communicate with you. And I think if we don't have any other questions, we'll say good night.